Good morning, everyone. Thank you for joining this special edition of NurseTOK, where we are going to be discussing kind of the COVID clinical care and looking after patients and managing patients with COVID. So thanks very much for finding the time to join us. By way of introduction, my name is Beth and I'm a nurse, currently working for the National Trauma Centre up in Darwin. And my background is intensive care. I'm an intensive care nurse and educator. And I'm very fortunate that we've got two colleagues with us that some of you, or most of you probably will know. We've got Erica, who is currently down in South Australia on holidays and has very kindly offered her expertise in joining us. So I might just get Erica to introduce herself and say hello to you all.
Thanks, Beth. It's really nice to be here. It's a bit cooler than my normal life in Darwin, so I've got a big jumper on. But yeah, thank you for inviting me, and I look forward to a really great session today. Thanks.
Beautiful. And then down in Sydney, our other invited guest is Dr. Tim Gray, who is an infectious diseases specialist and microbiologist. So I'll just get Tim to introduce himself and some of the experience he can bring to this webinar. Thanks, Tim.
Thanks very much, Beth, and hello all. Thank you for this opportunity to be with you today. As Beth mentioned, I'm an infectious disease doctor and manage patients with COVID in the hospital I work at in Sydney, and also run some diagnostic services as well. I'm very much involved also with the assessment for staff and any staff cases of COVID in our facility as well. So really happy to talk today and in particular answer any questions that might come up as well. It's a really difficult time when COVID comes to your country, and it doesn't matter where you are in the world, it really stresses even the best of systems. So happy to be with you today.
Yeah. Thanks, Tim. And I guess that, you know, really, Tim has just reiterated what this webinar is about. It's certainly an opportunity for you to ask questions to us and also to each other as well. We probably have health practitioners out there that have either been exposed to COVID patients in the past. There may be some of you out there that have not yet been exposed to COVID patients in the past and are maybe a little bit worried and frightened about that. And hopefully through this webinar, we will be able to help alleviate some of that worry and fear, because we will be concentrating on that very practical and applicable stuff with regard to looking after patients with COVID. So from our point of view then, so some of you may be aware that the National Critical Care and Trauma Response Centre sort of manage a lot of the OSMAT deployments from up here in Darwin, and as such, certainly Erica and Tim and myself have had a reasonable amount of experience in helping our friends in the Pacific respond and build capacity throughout the area in places like Fiji. Erica and Tim have recently deployed to the Solomon Islands, also been to Papua New Guinea, Timor-Leste, and a number of other countries. And we've got a team now just heading out to Vanuatu to help and work alongside our friends over there. So a lot of experience and lessons learned as well, I guess, from all the varying deployments in the Pacific. So this is just an example of how we've been working together with our friends in the Pacific, and this is actually a photo of the wonderful nurses and doctors at NurseTOK Hospital in Fiji. So I think probably one of the hardest things with COVID, certainly at the beginning of the COVID pandemic, and really now as well, is keeping up to date with how we care for people with COVID. As I'm sure you're aware, there are a number of guidelines out there that aim to inform us as healthcare practitioners of best practice and best research. But there is so much information out there, and it's really difficult to keep up to date with that information. It used to change on a daily basis, and even now this morning I've actually gone into our Australian version of the National COVID Evidence Task Force, and the slide that we had for a previous webinar was actually dated the 22nd of February, which really in reality seems reasonably recent, but having looked again, the latest update now is the 17th of March, which was a few days ago. So not always like keeping up to date with how things are progressing, but getting that information out to your colleagues and your friends as well also has its challenges. So I guess that changing of information day by day, sometimes hour to hour, can be quite difficult. So the World Health Organization also has their clinical management, living guidance of clinical management for COVID-19. So again, we all probably look to different places for guidance with regard to management of COVID, wherever we are in the world, whether that be in the Pacific or in Australia or over in Europe. But I think the one thing to remember is that whatever guidance we look for, it's usually reasonably similar, so that we're all ideally, what we want is all to be singing from the same hymn sheet. All right, so this webinar then is we'll be looking obviously at the severity of COVID and what are some of the simple interventions we can do to treat COVID. So COVID, whichever guidelines you look at, have been streamlined into sort of mild, moderate and severe symptoms. Your mild symptoms, so that's kind of classed as where people are reasonably okay. Mild symptoms may be just a little bit of a cough or just feeling generally unwell, but breathing wise they're okay, there's no signs of pneumonia, and they probably don't need to come into hospital for care. And then your moderate signs of pneumonia are you're feeling a little bit worse. You may have some difficulty in breathing, a little bit of fast breathing, possibly, especially on exertion. And if you were to take someone's saturation levels, they would usually be around about 90% on room air. Now, the severity of COVID that we're going to concentrate on today with regard to care and management of those patients is the severe COVID patients. And you can see here that what we're looking at with severe COVID is quite an elevated respiratory rate. So that fast breathing rate, sort of over 30 breaths a minute, which really, if you're breathing over 30 breaths a minute, you're gonna tire quite quickly. You're gonna get quite exhausted. So along with that comes your respiratory distress, or that high work of breathing, where your intercostals are receding and you're finding it hard to get your breath. And the other thing with severe COVID is when you put a SAT probe on someone with severe COVID on room air, usually their saturation levels are going to be less than 90%. All right. And then, of course, the critical COVID patients are really the ones that we don't want to see. We want to be able to do interventions during the moderate and severe stages in order to prevent our patients becoming critically unwell. And because the critically unwell COVID patients really are extremely sick and have less of a chance of survival if we let them get to that stage. All right, so your critical signs of COVID are certainly a respiratory distress, extremely low saturation levels and high work of breathing, a really bad pneumonia known as a respiratory distress syndrome. And a lot of these patients may require more intensive therapy and organ support. So as I said, what we'll concentrate on today is that severe COVID, where we can actually provide care in order to try and reduce the risk of people progressing to that critical stage, and recognizing when someone has severe COVID. So the way we're going to do this is through this kind of teaching tool, I guess, which I've got to give credit to one of my colleagues, Ant, who unfortunately can't be with us today, and also Erica, and a few other people who have been working on this teaching tool for the last number of months. And really what it concentrates on is the mnemonic pop-a-mop. And we'll be running through each of these letters throughout the webinar. So we'll be running through, so protecting ourselves through PPE is a really great way of caring, a good way of caring for a COVID patient. We'll be discussing oxygen and various therapies. Erica's going to run through the absolute importance of proning and positioning. And we'll also be discussing taking observations on these patients and some of the medications that you may have heard bandied around, and some of the medications that you have available to you as well in your facilities. We'll also be looking at other illnesses, because a lot of the time, and we certainly found this over in Australia, if with a 2-year-long pandemic, sometimes we have patients with COVID, but we forget that they may have other diseases as well that can contribute to their illness. So just being aware that we live in a world full of COVID, but also we live in a world where people also have other chronic diseases, and we mustn't forget about those. And then the last P, physio and rehabilitation, which Erica will also have a chat to you about, which is equally important. And just to let you know, this resource, I will make this resource available to you at the end of the session on our NurseTOK Facebook page. All right, so I'm going to hand over to Tim now, just to mention some of the aspects of PPE that are very important to consider when looking after infectious diseases, especially COVID.
Thank you very much, Beth. Look, I'm just going to make a few comments about this section. I think one of the things that we've learnt over COVID, over the long pandemic, over 2 years now, is that originally this was thought to be very much a hospital problem and hospital transmission problem. But the reality is, and we've seen it now with many waves, and I'm sure many of you that are on this meeting today know that this is very much a community problem, that you know that your family members are getting it, the people in the community are getting it. And our experience in Australia is that almost all our staff that are getting infected are getting it in the community. That's where that's happening. So I think the reason that PPE is important is that it protects us from patients who have COVID that we're looking after. In terms of the transmission from patients to healthcare workers, certainly at the start of the pandemic, and I think at the start of the outbreaks, perhaps in your country, you're not aware initially that the virus is in circulation, and it's when we don't know something that often catches us out. And that's where we certainly do see transmission in the hospital setting. We certainly see it between staff to other staff, if they're having lunch breaks together, or perhaps travelling to and from work together in vehicles. That's when we see transmission that's work-related. But I can tell you, in our setting in Australia and in COVID wards where we use the PPE, which we're going to talk about the details of that today, in actual fact, it is incredibly rare for us to see transmission from patients to healthcare workers. And the way I like to describe as I think about this is that these the healthcare workers, if you're working on the COVID ward, it's actually one of the safest places to be in the outbreak. It's where you've got your PPE on and it's your defence. And staff constantly tell me this, it's where they feel most safe. You know, going to the shops or coming to or from work in a vehicle, especially a shared vehicle, is a much higher risk. So I think while we're going to talk about the PPE for COVID, one of the general principles is that when you have got an outbreak, that you should be wearing a surgical mask around the hospital facility. If you're coming to and from work in a vehicle with others, you should make sure it's as well ventilated as possible and wear a surgical mask at all times in that vehicle as well. And it's a really sad thing about COVID, but one of the realities is if you're having your breaks, you need to do that away from other people. It doesn't mean that you can't have your lunch breaks with other people, but you do it in a way, ideally outside, places which are well ventilated. And if you're taking a mask off, make sure you're at least 1.5 meters away from others if you're doing that. And if you're doing that, the risk of transmission is significantly reduced. So just to summarise, one of the things that the kind of the mind shifts that I think is really important is that we often worry about getting COVID off our patients and in the hospital setting. But the sad thing about this virus is it's very much really a community problem and a problem of transmission from staff to staff. And in actual fact, if you wear the PPE as we're about to describe, when you're looking after patients with COVID, you feel really confident. There's actually probably in the setting of a community outbreak, one of the safest places to be is next to your COVID patient, knowing you've got that PPE on and being confident with putting it on, wearing it and taking it off. So I don't know, Beth, if the next slide has more things to talk about.
Yes, I think this is just a beautiful picture, which illustrates well, one, how important PPE is with regard to COVID, and it's probably, well, it is one of our best shields about with regard to infection prevention. And of course, along with a good level of PPE is our vaccines as well. So PPE and vaccines really are our shield in preventing transmission of COVID-19 in the workplace.
If I could make just one comment on that, just sorry to cut in. In terms of the vaccination, it's really important to follow your national guidelines for vaccination. And certainly if healthcare workers have been offered boosters in your country, you certainly should take those up. Because, you know, speaking anecdotally, we know where we've seen outbreaks of this virus in countries which have 100% vaccination with healthcare workers. The healthcare workers don't get, well, they can get the virus, of course, because the vaccine doesn't stop you necessarily getting the virus, but it is a shield against getting severe disease. And I feel very, you know, some of the Pacific countries that have had the very kind of robust responses in staff uptake of vaccination have ended up, you know, in this situation. It's very sad, people in the community not vaccinated are getting sick, but at least the healthcare workers, if they get the virus, are getting a mild illness and not ending up in hospital in the large part. So getting a booster when your country program says it's time to do it, please do that. It's what's going to keep you safe. And it actually does stop you getting the virus. It's just not perfect at stopping you getting the virus. It actually keeps your family safe as well, because if you do acquire it in the community or at work, then you're less likely to get it and less likely to transmit it at home. Thanks, Beth.
Great, thanks, Tim. Yeah, some really important information there. And just sort of explaining PPE. I think we're all used to the different levels of PPE. That, you know, in some places you may have a different level of PPE to another place. And just to give an example, so my understanding is that both Fiji and PNG use sort of this PPE that you can see in this photo. So a gown, a pair of gloves, an N95 mask, and some goggles and a face shield. This is also what we use throughout Australia as well now. There may be some places that wear some different PPE. Has anyone got any variations in PPE that they currently use or have used in the past that are willing to share, either in the chat or if you want to turn, I think if you want to turn your mic on.
Best, while we're waiting for people to make some comments, perhaps it's one of the things we have seen in some parts of the world and often in the media is people using the full body suits where you step into those and the zip up. And one of the things that points we like to make about that is that those don't offer any additional protection in addition to the PPE we're presenting today. And often we're worried when people put them on and take them off because they're more complicated, they're much more likely to contaminate themselves. So we recommend against using those. They're also, I know it's so hot, it's not hot where I am today, but where you are, it's so much hotter. And the open gowns at the back here, when done well, are so much more comfortable in that setting. But I don't want to cut off people from potentially sharing their experiences, but I thought it's worth mentioning that.
Yeah, thanks, Tim. And Ant was actually telling me a story the other day of they were doing maybe a PPE session, and people were doffing those full body coveralls, and unfortunately someone nearly fell over when they were doffing. So I guess that's a, you know, that potentially can be quite, it's not funny, but it can be quite dangerous. Those coveralls are can be very, very difficult to take off if you haven't practiced a lot. So as I say, a lot of patients are a lot of staff are using the level of PPE that you see in this picture here. I think we've got a question from Bronte that I can see.
Bula Vanaka, good morning, everybody. Just a quick comment from me. Also to note, what I'm sure you all know in the Pacific is that those coveralls are extremely hot. And in our climate, that makes it really challenging, both for staff fatigue and also the risk of breaching them is higher because it's very sweaty and it can be really quite difficult for you to provide nursing and medical care when wearing the full coverall. So it's actually much safer, as Dr. Tim mentioned. So it's something that in particular for our region and those of us that live in tropical climates, we've chosen to go with the safer level of PPE that maintains our ability to work effectively and safely don and doff them without risk for that. So rehydration in particular is one of the other really big challenges that comes with working in the red zone in those full coveralls. So it's just a comment really for those of us in tropical climates. Back to you, Beth.
Thanks, Bronte. All right, so this is just a quick short video on sort of the very beginning of your donning process. And basically we're not going to go through I'm not going to show you a 10-minute video on how to don and how to doff today, because that in itself is a whole different a whole session in itself. So what we're going to do is just quickly run over the main points of a safe donning technique and a safe doffing technique. And what this video just basically highlighted was, before you do don to go into a red zone, the first thing you really want to do is just make sure that you're bare below the elbows, and that you've actually, if you're wearing a street mask, that you remove that street mask before you start the donning process. And then this video is just highlighting the donning of the gowns that we were talking about just previously, what the gowns that Bronte and Tim mentioned. Some of the gowns that you may come across are, I guess, what we call surgical gowns, and they have the ability to be tied up at the front. What this video is demonstrating is that it's best probably think about not tying your gowns up at the front, because when we come to take the gowns off, which you'll see in the next video, it actually is really, really hard to take them off with that at the front. And when that gown becomes difficult to take off, that's when we run the risk of breaching and potentially, I guess, self-contamination. So when you are donning your gowns, make sure that you and your workmates and your buddies are tying those gowns up at the back. So we'll just try and play that video again to reinforce that. So tied up at the back. And then if you notice, he'll grab another set of ties in a moment. From the front, so those must also, so don't tie those up at the front, tie those up at the back as well. And the reason for this is the following. So with this video, just this demonstrates a really safe way of taking off your gown. So just notice how this lady is not touching the outside of the gown. She's only touching the inside of the gown. All right, so the inside of the sleeves, and she's rolling it down carefully. And then she's going to get her elbow to snap the ties at the back. And then really importantly, when she further rolls that gown up, she's keeping it away from her body so that she's not putting that dirty gown in contact with the rest of her clothes. All right. Has anyone got any questions about PPE before we move on? Because PPE is probably one of the most important aspects of caring for our COVID patients and keeping us as healthcare practitioners safe. I think Erica's keeping an eye on the chat there, so if there are any questions, hopefully she'll let me know.
No questions so far, Beth. All good.
Lovely, thanks, Erica. All right. And then just with regard to donning and doffing, as Bronte mentioned, where we all work, it's really, really hot and can be really, really humid. And again, this can add to the fatigue that we experience when working in our normal work environments. So I think it's from a brain functioning point of view, a cognitive point of view, sometimes having visual aids that are there to remind us what order we put our PP on and what order we take our PP off is really, really helpful. The other helpful thing and safe thing we can do is actually have what we call a buddy to watch us putting our PPE on and watching us taking our PPE off. And that then minimizes the risk of breaches, and it kind of it makes you feel like you're not alone, you're being supported, which I think is really, really important with COVID care. So here is just an example of the steps that you may use to put your PPE on. There are lots of potential variations out there, and that's okay. The important thing is that wherever you work, that everyone is doing the same. all right? When everyone does the same, it's much easier to remember what to do, and it's much easier to support your friends and colleagues when you are donning and doffing. And again, so I think it's, oh, Erica has got a question.
Sorry, when we get to the end, I was just going to get Tim to talk about some of the ideas around how long you can care for patients when you're wearing your PPE, and when sort of some of those ideas around limiting your exposure to patients and touching them and that kind of thing. That's probably best done once you finish talking about doffing. Sorry.
No, that's great, and really important to absolutely discuss that. And certainly, again, with doffing, really important that we again have a cognitive aid to help us with the safe steps of removing PPE. And again, what you currently do in your workplace may differ slightly to this poster, but again, it's about about consistency in steps where you work. All right, Tim, over to you.
Thank you. So to comment on the point, I think one of the things that's also kind of changed in the thinking of management of COVID over the years is this idea of limiting contact to as little as possible with patients. We've gained enormous confidence that this PPE works when put on well, when Beth mentioned having a buddy, seeing you putting it on, taking it off. And, you know, as I mentioned before, of the thousands and thousands of hours and literally hundreds of patients, over a couple of thousand patients come through my hospital with COVID, we've not had any transmission from a COVID positive patient to a staff member. And this is a PPE that we use that stops that happening. So because of that confidence, I think it's really important that if your patients need care, that you feel confident giving the care to your patients, and don't feel that you have to be limited to minimal time with the patient. Of course, keeping distance from the patient and being careful in your interactions, of course, makes sense. But on the other hand, caring for our patients with COVID is also very important. So holding their hand, touching them if they need that kind of support is very reasonable to do, knowing that this PPE works. In terms of when to change the PPE, I think the important thing here is that if it's contaminated, so if someone's coughed on you or there's fluid on you, then you should leave and get that PPE changed as soon as possible, because we would like to keep that contamination rate on the PPE as little as possible. But extended use of your mask and goggles is okay. So, for example, if you're looking after one patient and you're worried about the gown being contaminated, then taking that gown off and gloves off and then gown off and leaving that mask and goggles on is okay. We call that extended use of PPE. And in some ways, our staff feel much more confident. I feel confident with that too, because it's protecting the airway. Remembering the virus has to get in through the mouth and the nose to cause infection, and possibly the eyes as well, hence the goggles. But and the other question often comes up is whether you need both face shield and goggles. The answer to that is no, you don't need both. Just one or the other is okay. Some people like to wear both. One time where I think both is, if you've got access to it, is reasonable. If you're worried that a patient's going to bump you, or perhaps a patient's confused and lashing out, at least then if they bump your face shield, you've still got your goggles in place and makes you feel a bit more confident. But the routine use of both is not necessary. Whatever you kind of feel most confident wearing and what's available to you should be done. Was there anything else there, Erica, that we wanted to draw out there that you were alluding to?
No, I think that's fine. That's good. I think that covers it. I think, you know, something that we've encountered a little bit in our work, and certainly something that we were also thinking a lot about when COVID first came to Australia, was this idea that that we could put a time limit on exposure to patients. So some places had, you know, that you couldn't spend more than 15 minutes caring for a patient. And I think that, you know, we're pretty satisfied that those kind of rules don't apply anymore, provided that you have you've got your PPE on properly and you're wearing all of the layers of the PPE as we've described, that you can do what you need to do to care for your patients without needing to put a time limit on it. And certainly just from an AUSMAT perspective, you know, we've done quite a lot of work now in various places providing frontline care and using that PPE, and we haven't had any cases of OSMAT people contracting COVID from providing patient care. So we feel really confident in that, and we feel quite strongly that it's important that we don't compromise the quality of care we're providing our patients on the basis of outdated information that we now know is no longer accurate, and we can really be happy to provide the care that we need to these patients without worrying that it increases our risk of exposure.
I think if there's one take-home message, Beth, is that we want people on this meeting today to be filled with confidence that this PPE works. If they do this well, wear it well, then they are safe. And in fact, it's the safest place to be when there's an outbreak in the community. It's is on that COVID ward wearing a PPE, because it's a shield that protects us.
Absolutely. Thanks, Tim and Erica.
Can I just get Tim to speak about one more little thing that comes up a lot, and that is footwear, Tim. Do we need to wear gumboots?
So look, again, I don't want to contradict any local programs. So if there's local infection control practitioners that have views on this, it's really important to discuss with your local programs as well. We have moved away from using foot covers and dedicated footwear in units in our settings in Australia. And we're very confident with not using that footwear in that setting. Some people worry about taking the virus home to their families if they're wearing footwear, and what we'd recommend doing is just disinfecting the your shoes at the end of the day, or you could leave them outside your house if you haven't got access to disinfectant. But the actual risk, I've not seen any cases ever where we've felt even there's been any evidence that transmissions occur from shoes to a person. Remembering the virus has to be in the air or in droplets that get into your airway, so it doesn't jump off your shoes or come off your shoes. So from that point of view, talk to your local infection control practitioners. But in general, footwear adds very little in terms of protection, but does add complexity. And again, to allude to one of the earlier stories that Beth was saying, I've seen one person nearly fall over taking a shoe cover off in the areas as well. So it does add complexity to the care without probably providing any real meaningful protection to healthcare workers.
Thanks, Tim. So I think there's been quite a broad discussion around the PPE. So we're going to move on now to just highlighting some of the oxygen therapy that we can apply to patients with COVID. And again, we probably all have different forms of oxygen delivery systems in our places of work, and these may range from nasal prongs to just your normal face masks and your non-rebreather masks. Some places may also have that high flow nasal oxygen, and some places may have non-invasive ventilation. But the important thing to remember with any of these forms of oxygen therapy is that it's appropriate to the severity of illness and your patient's observations. Ideally, with COVID, we want to be targeting that oxygen saturation rate of 92%. So when you place that oxygen saturation probe onto your patient, we want to sort of have that target of around about 92% to ensure adequate oxygenation. Now, oxygen, I think we've all realised throughout the pandemic what such a valuable resource oxygen is, and I think we've all also realised that the oxygen consumption during the pandemic has been enormous everywhere in the world, to the point where we could be using 2 to 3 times as much oxygen for looking after during the pandemic than previously. So that's an awful lot of oxygen that we need to manage, that supply and demand, which has caused challenges as we all know, throughout the world. So if any of you were at our NurseTOK session last Wednesday, what I'm just going to run through now will be familiar to you. It's our oxygen ladder, and again we can post this resource up on the Facebook page after the session. And basically it's going to run through the different types of oxygen delivery system that we can apply to our patients, with regard to sort of targeting those oxygen saturations to between 90 to 93%. So at the kind of bottom of the ladder then, we've got our nasal prongs, which are really good for someone who, for COVID patients who aren't exhibiting too many signs of respiratory distress and just maybe need a little bit of oxygen to tie them over. Again, targeting to that 90 to 93%. So these nasal prongs are great. You can pop them onto an oxygen concentrator for low, what we call like that low flow oxygen. So anywhere between sort of 2 to 4 litres of oxygen. Some patients may require a little bit of a higher level of oxygen therapy, and that's where our Hudson mask comes into play. Some people call it a Hudson mask, some people call it a simple oxygen mask. It all depends on where you work. And this mask can deliver sort of flows between 5 to 10 litres. And then again, the next step up, which we probably all of us who have managed COVID patients have seen a reasonable amount of, is what we call our non-rebreather mask. And the difference between the Hudson mask and this non-rebreather mask is that you can see you have an oxygen reservoir bag here, and a couple of one-way valves in the mask there to facilitate the sort of the non-rebreathing of carbon dioxide, which is where this mask gets its name from. And with this mask, you can go sort of up for between 10 to 15 litres of oxygen a minute. So this mask tends to be for patients requiring that sort of higher level of oxygen therapy. And certainly we've learned that from people in throughout the Pacific, that it's also really helpful that if you kind of get to your ceiling of therapy with regard to your non-rebreather, you can also use a double source of oxygen. So your non-rebreather may be running with your oxygen, with your nasal cannula as well, which obviously offers a little bit more oxygen than just that one sole therapy. And here, so this is the oxygen ladder that we'll post on the Facebook page, because sometimes it's really difficult to remember sort of how much oxygen we can put through each of these masks or appliances. And just before I hand over to Erica, just with regard to these delivery systems, it's also really important to think about, once someone is on one of these delivery systems, to keep checking their saturation levels, because it might be that if someone's on a non-rebreather mask at 15 litres a minute and they have saturation levels of 98%, maybe we can think about lowering that oxygen level for them and bringing back how much oxygen you're giving them. And the glory of that is that maybe your patient is getting a little bit better, but also you are saving that valuable oxygen resource as well. So just have a think about, think about that as well. Very, very handy hint. All right, and Erica, I think we're on to proning and positioning now, which works wonders. So over to you, Erica.
Thanks, Beth. Yeah, so I'm going to be talking about proning and positioning, and I know that there are some people on the line who we might have spoken to about this already, but it's something that I get very excited about, and I feel for some of the panelists, Beth and Tim have listened to me get very excited about proning and positioning before. But I think that it's really the reason why I find it so exciting is that, one of our team members, I think it was in Fiji, but also similarly in the Solomon Islands, some of the staff there said to me that with COVID, it can be really hard to feel like you have treatments that will help you. There's no magic medicine for COVID, unfortunately, especially when people do become, moderately to severely unwell. And the thing with proning and positioning is that it can sometimes feel like the one thing that you can do with a patient that really can help them. And so it is something that is really important. Unfortunately, I think it's something that it gets left until a bit too late. And so I think that if you can sort of walk away from today's session understanding two things about proning and positioning, the first one is that it's really, really important and it's very helpful. And the second one is that if you're going to make the biggest difference for your patients, you're going to start at the moment they're admitted. Don't wait until your patients have deteriorated. Don't wait until they're really in trouble. The thing with proning and positioning is that it's a tool that can help prevent deterioration. It's not a magic treatment that will cure the virus. Okay, so if we start it early, we're giving our patients the best chance to get better and to survive. The thing is that the way proning and positioning, what it does is it helps oxygenation. So it can support increasing the oxygenation in someone's blood. And we've just spoken about, Beth has just spoken about how we can deliver oxygen into the patient and the ways in which we can escalate that. Just go back, Beth. And the thing is that what we're doing, particularly with proning, but with any kind of positioning, is we're actually putting the patient into a position where their lungs can best receive all of that oxygen that we're delivering. So the way I visualize how proning and positioning works is I think about the lungs as being two paper bags in the chest. And what we want in order for them to receive as much oxygen as they can is we want those bags to be big and open so that they can receive all of the good air that we're pushing into their faces with their oxygen. And so I just imagine what those paper bags are doing depending on what position the patient's in. So often we'll come along onto a COVID ward and the patients will be sitting in a crumpled heap at the bottom of their bed. They've slid down the backrest and they're sitting in a crumpled heap. And you can imagine that their lungs are not in a good position to receive that oxygen. So what we're doing with proning and positioning is we're actually putting them into a position that allows their oxygen to their lungs to receive that oxygen and for them their blood to become more oxygenated. Next one, please. So obviously, like with a lot of COVID treatments, published evidence is sort of catching up slowly with what we know from practice. But what seems to be the trick with proning is that the more you do it, the more effective it is. So in this study, they found that proning over 8 hours a day was really important. And my recommendation is that patients spend, around between 16 and 20 hours a day in a prone position, so lying on their tummy, if we want it to be really effective. And it also needs to start early, like I said before. So they're the critical things, is the amount of time they spend in a prone position and also that it started early. Next one, thanks. Yeah. So why do we want to prone someone? So first of all, I should have explained at the beginning. Proning is essentially someone lying on their stomach and that we do support them with some pillows, and we'll go through that in a little bit. But basically, it's lying in a position so that they're essentially lying pretty much directly on their front. And the reasons we do that are really to improve that oxygenation. So that lying, as you can see in the diagram, lying on your back, so in the left-hand side, we have when someone's in a supine position. So when we're lying on our back, we've got a lot of gravitational forces on our chest. Our heart is sitting over our lungs, and that compresses our lungs. We're also, when we're lying on our back, our gravity and just will put pressure on our abdominal organs, and that can push up into the diaphragm, which again, if we're thinking about lungs as being those paper bags, you've got the abdominal organs pushing up into the base of the lungs and reducing the volume essentially of those lungs. And what we want to do when we put someone on their tummy is we're taking away a lot of those gravitational forces. So we're allowing those lungs to actually expand and be in the best position to receive the oxygen. We're reducing the compression from the abdominal organs on the bottom part of the lungs. And we're also, it's a bit more, there's a lot, sort of bit more detail. I'm simplifying it a lot, but we are allowing the majority of the alveoli, which are located at the posterior part of the lung, we're allowing those alveoli to receive the most amount of oxygen. And the reason why this is all important is that it prevents deterioration. So it allows our patients to rest. And I think rest is one of the most underestimated factors in looking after COVID patients. So I'm not sure how much experience you all have in seeing someone who's been battling COVID. I'm sure there's some people who are well experienced and some for whom that experience is still to come. But I can tell you that people who are sick with COVID are sick for a long time. So they can be sick for weeks. And when you look at their saturations and you look at their heart rate and you look at their work of breathing, they look like someone who's just sprinted 100 meters, but they look like that 24 hours a day for weeks and weeks. Having COVID is really, really hard work. And because of the shortness of breath and the poor saturation, oxygen saturations, patients often don't get to sleep very much at all. Sometimes you'll talk to patients and they'll tell you that, you know, it's been weeks since they've had a proper rest. And the beautiful thing about proning is that sometimes, because you are putting them into a position where just purely from the position of their body, their oxygen saturations increase, their work of breathing can actually come down. So their respiratory rate comes down. Often their heart rate will come down. And often by the time you've finished observing them and making sure that proning is going to work for this patient, your patient will be fast asleep, because they're finally in a position where their body is able to rest and they will sleep. So, and that rest means that you are slowing down the fatigue, and fatigue is what will eventually kill our patients if we don't look after them, because they get so tired that they cannot keep fighting, and that's when their respiratory system starts to fail, and that's when they're looking at needing to be intubated. And obviously in a lot of places intubation isn't possible, and that, you know, that is, an intubation is often not effective either. So it's really critical. I'm not trying to scare you, but I'm really trying to help you understand that proning and positioning is not just like a bit of like fancy treatment that you do if you've got time. It really, along with oxygen, it really needs to be considered a core part of your patient treatment. Thanks, Beth. So this is just another couple of visual sort of examples of why being in a prone position makes a difference to your lung function. I think these CT cross sections are quite helpful for illustrating you know, why it's really important that we consider the positions of our patients. You know, there's really no point in delivering so much, as much oxygen as we can to our patients if we're not paying attention to their position and making sure that they're able to squeeze every little bit of benefit out of that oxygen by making sure that they're in a good position. Next one, thanks, Beth. So these are some beautiful pictures that were developed by the physiotherapy department at the Royal Darwin Hospital, using some of our local wildlife. So we've got the turtle and the gecko. But really what we're trying to illustrate here is that there's quite a few ways in which your patients can lie on their tummy. But the main thing is just that they are on their tummy. You can see, though, some fairly important aspects of what we've done here. So we always try to have at least 2 pillows, but often, having 4 can be really helpful depending on the size of the patient. So you can see that this gentleman is fairly sturdy. So we've got a few extra pillows for him, because what we're trying to do with these pillows is we're trying to reduce the compression on the abdomen. So we place a pillow under the chest. For the women, sort of between the neck and the breasts, and for the men, we really want that sort of right over the chest. And then the pillow that we put under the pelvis, we want to have it really low on the pelvis, so under the hip bones. And what that does is it creates essentially like 2 supports, and then we let the abdomen have this nice free space underneath here. And what that means is that because they're not lying directly on the abdomen, we're allowing the lung, the diaphragm to sort of relax down, and we're allowing those lungs to have the biggest possible position and be nice and open to receive that oxygen. What the patient chooses to do with their arms and their legs, as you can see in these pictures, that's entirely up to them. We want them to be comfortable. It's really important that they're really comfortable, because that's how they get the most out of this position. And if we want them to lie in this position for 16 to 20 hours a day, they need to be comfortable. The thing to remember is you want to support the head as well. And you do need to make sure when you do that, that you're not interrupting the flow of oxygen through whatever delivery device you're using. It can be a little bit tricky with the non-rebreather mask, because you do need to make sure that that bag is relatively straight and not too twisted or kinked. So you do have to fiddle around with that a little bit, but it's definitely possible. Next one, thanks, Beth. Oh, this is our favorite photo. This is Beth being the world's best patient. We were doing some teaching in Fiji, in Lautoka, and I have to say, in Fiji, they had the world's best pillows. We called them golden nuggets. They're the best pillows for proning because they are really nice and firm. And so, yeah, you can see, Beth's in a pretty comfy position there, despite the fact it was quite hot in that tent. It was good. And, I know that, COVID patients can be a bit scary, because once they're in hospital, they can look quite unstable, and they are unstable at times. And there's certainly some, contraindications and some delicate sort of details around proning that you do need to think about. But I really want to encourage you guys to try proning your patients, and because it can make a difference. And it is relatively low risk compared to, the more invasive treatments that patients will require if they deteriorate. Next one, Beth. So this is in PNG, some lovely nursing staff members there. We were practicing our proning. The other thing, so this section is called proning and positioning. So the thing, obviously not all patients will tolerate being proned, and maybe there's reasons why they can't be proned. And also we like to, because we want to look after patients' skin, and patients need a bit of variety, we need to also think about what positions they're in when they're not in prone. So lying on your side like this is a really lovely way of also supporting respiratory function. So I've come across a lot of patients that for various reasons don't like to be in prone. And so they actually also get similar benefit to their oxygenation and improving their saturations and improving their rest when they're lying on the side. The thing to remember about side lying though is that it needs to be true side lying, not semi-supine, okay? Next one. And then also, if patients want to sit up, if they want to have a break from lying down, this is also a really great position where you're supporting their upper body. Their lungs are nice and open. They're not all hunched over, and they don't have a sort of collapsed inwards kind of position, but they're sort of sitting up, their upper body supported, and they're getting a good amount of expansion through their lungs. That's it. Is there any? I'll just check the chat. There was a little. Oh, yep. So please feel free to ask any questions. Maybe towards the end of the session, and certainly I will be available to share some resources and answer any questions about proning and positioning. Thank you.
Great, thanks, Erica. So moving on to observations, I kind of alluded to this earlier on when we were talking about oxygen, and just really thinking about the importance of, once you apply oxygen and position your patient appropriately, it's about that continuous monitoring where possible. So probably the recommendations, I think both in the World Health Organization and probably your local guidelines as well, would probably recommend at least every couple of hours checking your patient's respiratory rate and oxygen saturation levels to see whether there is the potential to pull back a little bit on the oxygen that's being delivered, or possibly do we need to escalate oxygen therapy. And also it's always good to talk to your patients as well, to see how they're feeling. Are they feeling any better or worse? Because again, it's the talking to your patient and looking at your patient, they're going to be the best indication of how they're going. And I guess really one of the most important things is that if your patient is getting worse, don't feel that you have to battle with that yourself. Please get help. Having a united front with a deteriorating patient is really in the patient's best interest. And yeah, again, as we mentioned earlier, in COVID, the most important vital signs really are respiratory rate and saturations. And I'm going to add in talking to your patient as well. What's this? So I might get Tim. Are you happy to talk and elaborate on?
Okay. Yes, Beth. No problem. I think one of the things is that patients can suddenly change their clinical state with COVID. It's one of the things that's been really challenging for the clinical management. I know many people in this meeting today have seen these patients that one moment look okay and the next minute are quite hypoxic. And it can affect any age, but particularly younger people as well, because we've kind of the younger person, which it's my birthday today. I feel very old today, but the younger people, which I don't count myself as anymore, can much fitter and can get sicker much more quickly. So it's just something to be watchful for on the ward, and so they can look quite well, but you put the oxygen saturation on and find it's 85% or 88%. So trust that machine and intervene. Even if people look well, we'll get a second machine if you don't trust the result to check the oxygen levels. So people can look well for a long time with COVID and often present looking quite unwell, looking quite well, but quite dangerously hypoxic.
So sort of alluding to that as well, if you were faced with a patient that presented to your clinic or already was an inpatient who had a respirate of 24 and oxygen saturations of 93%, the question probably is, well, how worried would you be? I mean, a respirate of 24 and saturations of 93% is kind of, it looks reasonably all right. You may have a low level of concern there. However, with this slide, there's probably one piece of important information that's missing. Can anyone think what that might be? You're probably all thinking hard, and you probably all know the answer. How much oxygen are they on? If I then told you that the patient had saturations of 93% and a rest rate of 24, but were already on 15 litres via the non-rebreather, then your level of worry has already escalated. All right. So really, it is so important that we not only record our patients' respiratory rate and saturation levels, but it's also really important to record how much oxygen that your patient is on, so that the team of people that are looking after that patient are aware of whether your patient is deteriorating or not. Okay.
Oh, can I just add to that, Beth?
Yes.
Another thing that's worth documenting and paying attention to when you're doing your observations is actually whether or not someone is prone or in a good, or what position they're in, because one of the things when we're thinking about looking after COVID patients is we often have a very firm ceiling of care, and so when we are thinking about how sick a patient is, if a patient's saturations are 93% when they're in prone and they're already on double source oxygen, so maybe they're getting 15 litres through 2 oxygen cylinders, and we know and they're only still at 93% lying in prone, we are very, very worried about that patient, and that's something that we need to make sure we've escalated to everyone that needs to know. So if I'm as an allied health person, I would be making sure that the nursing staff know, and I would be making sure that the doctors know. If I was a nurse, same thing, I'd be making sure that the doctors and the senior nurses know. So paying attention to the positioning as well as the amount of oxygen they're receiving and all of those things is really important, because it helps us to know how to respond.
Lovely, thanks, Erica. Has someone got a question? No? Sorry.
So Beth, if you want me to talk to the medications here, I think the kind of key kind of principles here is there's a few medications which we should be thinking about in our patients with COVID, and one of those is dexamethasone. And it's the tricky thing about dexamethasone is that we don't want to be using this for our patients who are not hypoxic. In actual fact, in the studies, it showed our patients that weren't requiring oxygen and were saturating okay on room air, they did worse if we gave them dexamethasone. Having said that, if a patient has got hypoxia, then dexamethasone leads to a better outcome for them. So what this means in practice is we should be monitoring the saturations for our patients, and once they require oxygen, then we should be prescribing dexamethasone to them. The second medication to think about is heparin. So this could be Clexane or other forms of heparin. And the thing to remember about COVID is that it's a disease that promotes clotting in the body. So our patients with COVID, often we think about the lungs, but we also need to think about the blood vessels and the fact that they're more likely to have clots develop. And for that reason, we should be using heparin or Clexane in our patients, or definitely with our patients with more severe disease. The evidence is strongest there. We should definitely be doing that. The patients that come with mild disease, practice does vary. My clinical practice is to use heparin or Clexane in all patients because there is a risk of patients being in hospital for getting clot. But the benefit in those less severe patients of the Clexane is a little bit less, the heparin is a little bit less. And so it depends on your local resources and what's available. You may choose this to do it with the patients who have more moderate to severe disease, or you may do it in all patients. Both are reasonable approaches, and you should be talking to your clinical COVID leads locally about what your local protocols will say for that. Antibiotics is one thing that comes up often. These patients often look very sick. They've got fevers, and we do see patients have secondary bacterial pneumonias, and so we should be thinking about that and following your local antibiotic guidelines for community-acquired pneumonia if patients are concerned to have a bacterial infection. We've got some doses here. If you don't have dexamethasone, you can use prednisolone, 40 milligrams. It's a big dose, or hydrocortisone if you're unable to take oral medications in the dose that's given there. The other thing to remember is that steroids it's a double-edged sword. They're really good at patients who have severe COVID, but for patients, even with severe COVID, whenever we use steroids, what we're doing is dampening down the immune response. And what this means is patients have underlying infections, things like tuberculosis or perhaps some parasitic infections, they can resurface and cause some problems. So the general principle here is that for COVID, we'd use it to treat it, but once they improve, we should stop it. So if they're off oxygen for a day or so, then we stop the dexamethasone. And certainly we don't send home patients on dexamethasone or steroids. If they're well enough to be off oxygen and to go home, they should be off the steroid medication, unless there was another reason to give it. Perhaps it got asthma and it's been exacerbated as part of the illness. It'll be a different reason. But for COVID, we definitely want to stop it in that setting. The only other medication I want to mention very quickly, because it comes up often in discussions, is the use of ivermectin. So you'd be familiar with this medication. It's an anti-parasitic medication, and you may have reason to use it in your setting to treat strongyloides or other parasitic infections. And early on in COVID, there were some studies, very small studies, that showed there might have been some benefit, but the evidence is overwhelming now that it does not help patients with COVID. It's an unnecessary medication to give to patients, and there's no infectious disease specialist in Australia that would recommend using ivermectin now to treat COVID. So you should not be using it to treat COVID unless you've got concerns about some parasitic infection or some other indication. Please don't use ivermectin for these patients. As antibiotics we've discussed already, it comes up often. I think the antibiotics are given because we're anxious about the clinical state of the patient, but just to follow your community guidelines for pneumonia is hospital-acquired pneumonia, if they've been in hospital for a while, is what we'd recommend. Fluid resuscitation is very important. Often these patients come in after several days of being unwell at home. They may not be able to take fluids because the nausea perhaps, and diarrhea, as you might know, can be a presenting complaint for COVID as well. So these patients often, not infrequently, present with dehydration. So managing the fluid status is important. And as you know, in Pacific Islands, you do very well. Oral fluids are good as long as they're not vomiting. Is a very good and safe way to replace fluids. But if they're coming in deficit, then IV fluids, at least initially, is an important part of the resuscitation. I think on this one here, Beth, I'm happy to make some general comments, and maybe others want to as well. But I think one of the things we've learned in COVID outbreaks and in our patients that come in with COVID is there's often the patients that have other medical problems that do very poorly. And often many of our patients that die, we think of COVID, actually dying with COVID, and they've got other causes causing their demise. So, for example, we've had patients that have had clear bacterial pneumonias that made them very sick. And they might come in, we've had patients with appendicitis or other surgical problems that come in and have COVID as well. So it's really important that these other problems get managed very well. Diabetes is obviously a very important comorbidity. They tend to get more severe disease and may end up in your hospital facilities, and managing that diabetes is an important part of the management as well. So this being a common problem in the community, at the moment, about 2% of the state I live in New South Wales is infectious with COVID today. As I talk, and I imagine in your countries, if you've got significant outbreaks, it may even be higher than that. So it's to remember that when you're talking about that many people with the virus at one time, there are going to be people coming in with other comorbidities and other problems. So don't forget to manage these, and don't put them in a corner and forget about these problems, because that's more likely to cause them harm than the COVID virus is to them.
And the last P, over to Erica for physio and rehab. Last but not least, Erica.
Oh, that's right. It's very true. No, so this carries on really nicely from what Tim was just saying about other illnesses. That it's really important that we get our allied health people involved. So physio and rehabilitation assistants and our whole sort of rehabilitation system. I believe, and but obviously it depends on local situations, but there's a big role for allied health, particularly physiotherapy, in acute phases of COVID treatment. We can be very supportive in terms of helping with proning and positioning. We can start some early mobilisation when patients are safe enough to start moving again. We know that COVID as a disease on its own can have really profound impacts on people's ability to care for themselves, their ability to basically participate in their daily lives. So that might be through significant breathlessness and poor exercise tolerance as they recover. They might have significant musculoskeletal problems from, basically weakness, muscle atrophy, particularly if they've spent a long period of time in ICU. There are also some other issues relating specifically to COVID that we're sort of learning more about as we go along. So things like neurological problems, inflammatory problems, pain, cognitive issues. But essentially, the earlier you get physiotherapy and rehabilitation involved, the better it is for them to be, the easier it is for patients to be included into that system, and so that they can be followed up as necessary. The other issue, though, is that the other conditions that require rehabilitation can also exist alongside COVID infection, and those things won't stop because you have significant outbreaks in your community. People are still going to have strokes. People will still require amputations, either because of vascular problems or through trauma. People will continue to have spinal cord injuries. So all of those conditions that normally require rehabilitation and support from long-term support by physiotherapy and other rehabilitation professions will also get COVID. And it's really important that we don't avoid them because of the COVID. So we need to make sure that we're activating those systems in the same way that we would normally, but just with that additional layer of protection through PPE and other infection prevention and control systems, so that we don't delay treatment that we know can really significantly improve someone's long-term outcomes after injury or illness. So when you're doing things in your hospital, don't forget about your allied health staff. Don't forget about your rehab system. Don't forget about your physios. They're a really, really valuable tool, but too many times I've seen in many different countries that they kind of get forgotten and often or they get excluded because people are trying to protect them. But my opinion is, if you teach them PPE, if you teach them infection prevention and control, then you are maximizing the use of your resources, and they're also a group of professionals that have really important skills that will be really valued for your patients.
And I think Erica has explained that extremely well. That brings us on to another beautiful photo that illustrates working together as a team. That really is the crux of everything we have run through today with regard to our pop-em-op mnemonic. There really is so much value in doctors, nurses, allied health and other health professionals working together, with the focus being on the outcomes of the patients. So really, as I say, that's what this photo is supposed to or does illustrate. Now I think we're coming towards the end of the webinar, so just to reinforce again, we'll put this pop-em-op resource up on the Facebook page so that you can all have a look at it and pass amongst your colleagues and friends if you so wish. And a slide from Antu, unfortunately, as I said, can't be here today. Go forth and save those COVID patients. Sorry, my pigeon is not very good. If anyone can help me out, I'd be more than happy. And just,
So, no, go.
Oh, sorry. And then what we'll also do, because we absolutely understand that we've probably covered an enormous amount of information over the last sort of hour and nearly an hour and a half. So we have put together a website that I will also put the link up to on the Facebook page, that will give you a link to all of the COVID care resources that we've sort of developed and gathered over the last couple of years. And that includes videos that have been filmed by our friends throughout the Pacific on oxygen therapy, monitoring saturation levels. We've also got the POPAMOP guideline in there. We've also got a lot of proning and positioning resources as well. So look out for that coming up onto the website today. And that is it for today. Thank you so much for finding the time.
Just a couple of questions we need to wrap up, Beth. Sorry, I wasn't sure if you were going to wrap up.
No, yeah, so, no, carry on.
But Tim, you might be able to help us out with these. So we have a question from Tonga. If we were to do rat surveillance for home quarantine cases, these are repatriated cases of the same bubble. Do we need to don and doff for every house after each rat, or just change gowns, or just sanitize?
So the first thing I'd say is it'd be really important to have local protocols for this, because I could say one thing, I'm happy to tell you what I think about it, but it's very important that, before implementing changes, that it's kind of agreed across the program, particularly for quarantine type services, which are often appropriately under the eyes of government and health officials. A crystal ball looking into the future with COVID, which can be dangerous, but I suspect in the future that we'll move away from using gowns and gloves for managing COVID cases. As I said before, COVID comes to us through the airway, through the mouth and nose. I'm not advocating we move away from that now. The WHO and other organisations recommend the use of gloves and gowns at the moment, but the transmission through those surfaces is very minimal. It's not minimal. It's not plausible biologically. The virus it just doesn't go through the skin. It does get in through the respiratory tract. In terms of what we do locally for this, is that we've moved away from using gowns for collection of swabs on patients who are not known to be positive for COVID, who are asymptomatic, so for screening. And we have a method where we do that in our staff clinics in particular for surveillance, and it could apply to the home quarantine system as well, where the person stands off to the side when they collect the swabs, so they don't get coughed on. But you must wear your eye protection, you must wear your respiratory tract infection. That definitely can be worn between patients. If there's the use of gowns in place for this, which is reasonable as well, you can use those between patients, but for individual episodes of patient care, we like gloves being changed. And I think in the Pacific context, what often's done, you should have a second pair of gloves, because it's very hard, I know, being there recently, changing that pair of gloves when it's so hot and sweaty to get a second pair on appropriately. So the general principles in infection control, we should be changing gloves between patients, and the gown definitely can be extended use. There's no harm with that unless it gets contaminated. And I'd advocate very strongly that the gloves, the eyewear protection and the respiratory protection is continuous use as well. So in summary, changing the gloves between patients is important, but that could be a second pair of gloves you wear over the top. But the other PPE, I think, would stay in place between patient collections. You're not going to give COVID to anybody by keeping a gown on between patients, but do run that by your local program first and your local infection control practitioners to make sure you have local agreement on that.
And just with that, if you are doing work in the community, the other thing to just think about is, if you're walking between houses, then that's one thing. But if you're then getting into a vehicle and traveling with other people in a vehicle, then you do need to think about that with a bit more detail as well. So they're just the contextual things that are a little bit different, but that it's worth developing a guideline so that everyone's kind of consistently following that.
It's a good point. Certainly in a car, that we wouldn't advocate people wear gloves and gowns. You should be taking your gloves off outside of clinical context and using hand sanitizer in that setting. So driving around in gloves and gowns would be inappropriate, because it's it's unnecessary, but also increased risk of contamination back into the environment again.
So, Fala Mahina, I hope that answered your question. Let us know in the chat if they have any more clarification. And also, so we have a question from an anonymous attendee. Is it really necessary for staff looking after COVID positive cases to be isolated for days before going back home? And Tim, I know you can answer this.
Well, this question it comes up commonly, and certainly in our context, it used to come up as well. So, look, again, I really hope one of the take-home messages from today's webinar session is that I want you to have confidence in the PPE you're wearing at work. And it follows, if we're confident in the PPE use, is that there's no need to isolate before going home. And to restate the thing I've stated earlier is that this virus, when it comes to our communities, it is a community virus. And of course, hospitals are part of the community, and therefore it goes through the community group. But I can tell you in the last month, we've dealt with literally over 100 staff infections at our hospital, one of the hospitals I work at, and we interview all of them to find out where it's come from. And I can tell you that 98% of these or more acquired at home. They've got a family member that's positive. They've been to a wedding where there's been cases. They've got a child or partner that's positive. That's where we're seeing the transmission in that community close context. Workplace transmission definitely can happen, but I can tell you that transmission from patients to a healthcare worker hasn't happened in my hospital in the recent 2 outbreaks. It did happen early on when we weren't expecting the virus to be around as it's ramping up when it first arrives. But once the PPE is put in place, it doesn't transmit in that setting. So the answer to your question is no, we don't recommend isolation of healthcare workers before returning to the community, because community is where the actual risk is, more so than hospitals, where we should be feeling really safe with our PPE.
Another question, Tim. Is it okay to wear your eyeglasses, or do you need to wear goggles?
Yeah, this question comes up often. The problem with eyeglasses is that, and I appreciate that they don't come around to the side. So the benefit of actual goggles or face shield over eyeglasses might be a good alternative for people. Is that the benefit of that is that if you're working with a patient with COVID at the side and they cough next to you, then you don't have protection of your eyeglasses like Erica's working there, because you see this big gap on the screen there between Erica's glasses and her face through the side, whereas she's wearing goggles that comes around and close that over. So again, I don't have any data that says it's safer than not, but certainly all the guidelines recommend using goggles over eyewear. And I appreciate that it is difficult and not everyone has access to face shields, but face shields over eyewear is one particular solution, or you find a particular eyewear that suits your goggles that suits your eyewear well, and then keep hanging on to that particular type, because there are various types and some of them are bigger than others and can meet that purpose. So yes, the answer is that the guidelines say we should do that, and it probably does offer a little bit more protection to you.
We've got one more question, and I think that I know what you're going to say, but that's okay. We'll ask it anyway. From Latu. So thank you so much for the presentation and questions. Let's say if I have someone I live with at home who is positive, how long before I can look at going back to work?
So this is a difficult question to answer, and there's kind of various approaches to this. And I think one of the things that we know when COVID comes to our communities is that the workforce is under enormous stress. And we have patients that are sick in the hospital that desperately need care. And so what we're doing is balancing the risks of someone coming to work that might have COVID from the community with the risk of not having enough staff to look after patients and keeping the hospital run. And the balance that we've come to with the particularly Omicron strain in my setting is that we recommend 7 days isolation away from work, and on the 8th day you can come back to work. Having said that, we've been very desperate in our setting. We had one situation, we had a whole ward full of patients in the hospital working in Sydney, and we only had one nurse available because all the others had COVID or had from community, not from work, or had a family member that had COVID. So we actually, in that situation, made a decision that on balance, bringing back those staff members to work, making sure they wear their PPE and their mask at all time, particularly around staff as well as patients, that was a reasonable thing to do. Your countries are going to have guidelines around this, so I don't want to overrule what your local experts are saying, because often there's often cultural issues as well, and we want people to feel really confident with coming to work in a space that they feel safe. So do ask your local leaders, but my take is Omicron in particular, that most transmission will occur within the 5 days, and 7 days gives that bit of extra safety net. But if you've got a big family, of course it could be more than 7 days, because transmission could be happening between various family members and eventually find you after day 7 if that's your situation. So it's a tricky one to answer, but it's I think that the thing to remember is that we can mitigate the risk of transmission of COVID significantly by wearing masks around the workplace, avoiding having staff having breaks together, and on balance, they're bringing people back at day 7. It used to be day 14, by the way, we kept people away for, but on balance, it just seemed too long in our setting.
And that's all for all the questions. Does anyone have any last questions? Please don't be shy. We're really happy to discuss things with you. And often I think the most value comes from the discussion from questions. So if anyone has any questions, don't hesitate. But otherwise, yeah, that might be.
Can I make a suggestion with the questions? Maybe if people have got more questions or think of questions after we've gone, pop them in the NurseTOK Facebook group, and we can have a look at having a discussion there, maybe.
Absolutely.
I think people are starting to have other commitments now, and are starting to leave. So I think we might leave it there. So thank you to everyone for coming, and especially for all of, as Eric said, all the great questions that you've asked. It really does make it worthwhile with the questions. And special thank yous to Tim for finding the time to come and join us as well. And
on your birthday, Tim.
On your birthday, happiest of birthdays. And also Erica as well, who's taken time out of a little holiday to come and join us. So thank you all. All right, and we'll see you at the next NurseTOK on the 13th of April, hopefully. So thanks very much. Have a great day. See ya.
Bye, everyone.